Our next talk is from Dr. Karen Canfell, and she'll be discussing the cost effectiveness of HPV vaccination in high-income countries. Thank you.
Thank you very much, Mark. And I'd like to start by disclosing I'm currently involved in configuring a trial of primary HPV screening in Australia, which will involve support from a number of manufacturers. So I'd like to also say that this presentation is based on a paper that will appear in the special vaccine supplement in your conference packs, and I'd like to acknowledge my co-authors in this article, including Jane Kim. So the objectives of our review of the literature of the cost-effectiveness evaluations of HPV vaccination in developed countries was to provide an updated snapshot of model evaluations of cost-effectiveness of HPV vaccination, and therefore to provide an overview of current areas of consensus which particularly relate to vaccination of pre-adolescent females. But there are a number of areas of emerging challenges, particularly in evaluating male vaccination, the choice of vaccine type, whether bivalent, quadrivalent, or new next generation emerging non-valent vaccines that will protect against up to 90% of cervical cancers. And I think a very important area is the interaction between cervical screening and vaccination. And so by doing this, we hope to signpost the way forward for modelling research. So there are a number of elements needed for comprehensive modelling of HPV prevention. And though many, or probably in fact all models simplify in one or more of these areas to some degree, it's important to consider these elements in relation to the type of evaluation that's performed. First of all, models need to consider HPV infection, and the most comprehensive way to do this is to use dynamic models which consider changing rates of infection in the population over time, and thus can model the effects of herd immunity. Models vary widely in the number and type of HPV disease outcomes that are considered. And for cost-effectiveness evaluation of HPV vaccination, the most comprehensive evaluations consider all HPV disease-related outcomes, whether or not the intervention is confined to females. It will consider outcomes in both males and females. There's another category of evaluation of cervical screening, and these evaluations need more detailed models of screening events, diagnostic confirmation and workup, and post-treatment test of cure. As Jane explained, these models can then be used to calculate cost per life year saved or cost per QALY for a particular preventative intervention. And this is compared to a willingness to pay threshold in a particular setting. Now, the last vaccine monograph, which was published in 2008, had identified at that time 9 cost-effectiveness studies of HPV vaccination, mostly done in North America. And for this exercise, we performed an updated systematic review with a final search in March this year. And we identified 43 evaluations, and I think the big difference has been the emergence of a plethora of new evaluations driven by health technology assessment processes, predominantly in Europe and to some extent in Asia. And in these evaluations, it's important to note that the cost per vaccinated individual, which, as Jane explained, is sort of a bundled cost including 3 doses plus delivery costs, varied from about $360 to $500 in North America, with equivalent rates in other countries. So that's roughly $100 per dose. So the vast majority of these evaluations, with a notable exception of one in the Netherlands, found that vaccination would be cost-effective compared to the local willingness to pay threshold. That's vaccination of pre-adolescent females. And it is notable that multiple evaluations by different groups have been reported in several countries as listed there. And it is also notable that although these all came in under the willingness to pay threshold, the absolute value of the cost-effectiveness ratio did vary quite considerably, and this is a function of the different assumptions used in models. So for example, in the UK, there's up to a 6-fold difference in the results for some of the different evaluations. Overall, the results of these evaluations are most sensitive to the duration of protection and the consequent need or otherwise for boosters. However, the final decision on cost-effectiveness of young females seems remarkably insensitive to either the type of model used, whether outcomes beyond cervical cancer included or not, or the range of the cost per vaccinated individual within a certain range. And it's notable that, in fact, this range was in fact fairly limited. And so there appears to be a considerable margin of error in evaluation of this policy question. And what I mean by that is it appears that vaccination of pre-adolescent females is very cost effective. And it's worth noting as well that the prices have probably dropped in accredited programs in many countries, which would give us further reassurance that this is a highly cost-effective intervention, even in the context of organised cervical screening programs. So why is female vaccination so cost-effective? Well, of course, in the first instance, one of the reasons is that it's highly effective. And this is a modelled evaluation example from Australia, which shows the predictions on, using a dynamic model, the predictions for the decrease in HPV infections. And you can see from the start of the vaccination program to within a few years after starting, a rapid drop predicted. And we predicted at that time a decrease of about 68% using 3-dose coverage rates, or 77% if one assumed that 2 doses provided full protection. And as Suzanne Garland presented this morning, this has now been backed up by observed data published a couple of weeks ago showing an observed 77% decrease in the first few years of the vaccination program in vaccine-included types in females aged 18 to 24 years in Australia. So of course, effectiveness is not the whole story. The other aspect for female vaccination is the relatively high burden of disease of cervical cancer, again, even in context of cervical screening programs in relation to the burden of HPV-related disease in males. Now, the assessment of male vaccination cost-effective is quite a bit more complex. It does have potential benefits, and these include direct protection against male HPV-related cancers and anogenital warts, and indirect benefits to non-vaccinated females. But a priori, the return on investment should be lower than female-only vaccination because the burden of disease in males is lower, but also because heterosexual males, at least, benefit from female-only vaccination via herd immunity, particularly if coverage in females is high. And at the time of our review, we identified 6 comprehensive evaluations looking at male and female vaccination versus female-only vaccination, mainly in the US, mainly dynamic models needed for the assessment of herd immunity, so critical to this question. And again, these assumed a high cost per vaccinated individual. And this slide summarises the results of the US studies. And you can see across the top increasing cost effectiveness ratios for increasing levels of coverage in females. And as we go down the slide, we see decreasing cost effectiveness ratios or more cost effective results as we include more HPV-related disease outcomes. But what we can say from this is that if vaccination in females is at less than 50% coverage, then vaccination in males is more likely to be cost effective at these vaccine prices. But if coverage rates in females are over 70%, then it's unlikely that at these prices, vaccination of males will be cost effective. So consequently, a 50% threshold for the female coverage has been proposed in order for male vaccination to be cost effective. And certainly the lower coverage rates in females in the US did inform the decision to recommend male vaccination in that country. It's also notable, though, that even though male vaccination might be cost-effective in such circumstances, it's not necessarily true that it is the most cost-effective intervention to make. So Harold Chesson, for example, has looked at the situation that with current US prices and with coverage less than 50% in females in the US, increasing coverage of girls is actually a more cost-effective option than adding males, even if this incurs an additional $350 of program cost per additional girl. But of course, the cost effectiveness ratio is highly sensitive to costs. So by definition, there must exist a threshold vaccine price that will make male vaccination cost effective for any particular female coverage rate. And it's notable that the recent decision to vaccinate males in Australia in context of over 70% coverage in females was contingent on a pricing agreement being reached with the manufacturer. And to put that into context, the first 4 years of vaccine introduction in females in Australia was budgeted at about $400 million. The first 4 years of male vaccination was budgeted at $20 million, which is about enough to cover the costs of the registers and so on. So we can infer from that that the vaccination of males is more or less cost neutral to government in that setting. Now, I'll just cover briefly the emerging area of evaluation of choice of vaccine type. A number of comparisons of bivalent and quadrivalent vaccines have been made, and ultimately this depends on a number of trade-offs, including the duration of direct protection associated with vaccine-included types for each vaccine, the extent and duration of cross-protection, and the inclusion in the quadrivalent vaccine of protection against anogenital warts and RRP. So various threshold analyses have been done on the cost that the bivalent vaccine would have to be equivalent cost effectiveness to the quadrivalent vaccine. And more or less, they come out at about 20 to 40% cheaper, that would need to be the target price for bivalent vaccine. The first evaluation of non-valent vaccines in Canadian context has been performed recently by Mark Brisson's group, and they estimated that the cumulative incidence of cervical cancer over 70 years, assuming 70% coverage, would reduce by 32% for bivalent vaccine, 31% for quadrivalent, and adding in a non-valent vaccine would result in an additional 5 or 7% respectively protection over that time. Now, the evaluation of vaccination impact on screening depends importantly on the timing and extent of vaccination impact, and this is expected to be highly country specific. It will depend on the year of vaccination commencement, the age of catch-up for vaccination, and the coverage rates for vaccination, as well as the age of starting screening. And if we look at these parameters, we can see why vaccine impact on screening is happening so quickly in Australia, for example, which was one of the first countries to implement national HPV vaccination, had a catch-up to age 26, has high coverage rates, and has an early age of starting screening of 18 years. But it will be important for us to evaluate the impact of this vaccination on the timing and effect of this change to screening. And one way to put a formal metric to it is to look at the cost effectiveness of screening and how this changes in the light of vaccination. And this is a recent evaluation that we performed for New Zealand, which we're presenting here at the Hpv meeting. And it shows that in the pre-vaccination era, the cost effectiveness of HPV vaccination in New Zealand was right on the willingness to pay threshold of about 20,000 New Zealand dollars per life year saved. But you can see for different vaccine coverage rates, this is 25%, 50% and 75%, screening becomes rapidly less cost effective over time. And we can see by 2020 it approaches nearly its maximum value. The actual coverage rate in New Zealand is about 50%, and we're looking at a 50% increase in cost effectiveness. So what this really means formally is that one should be considering some kind of disinvestment once an intervention becomes non-cost effective. But of course, we'd all like to see that disinvestment result in as good or better outcomes for screening. And I think the way forward on this is clearly moving to primary HPV screening. And there's a new category of evaluations emerging which will need to consider primary HPV screening in context of increasing the age of starting screening and increasing the screening interval, which is one of the important factors driving the cost effectiveness of HPV screening. It will need to consider, as was mentioned this morning, the effect of compliance with screening recommendations, because if women are over-screened, this will have a detrimental effect on the cost effectiveness of HPV-based screening. And there's a new category of evaluations looking at, is any screening at all going to be cost effective in women who've received a non-valent vaccine? And an initial evaluation in the Netherlands suggested that HPV screening would still remain cost effective if it was conducted once or twice per lifetime. These evaluations will need to consider the emergence of new automated platforms and competitive costing driving the price down. And in particular, they'll need to consider a range of triaging options for the management of HPV positive women. And there's a number of options have been considered and floated so far, and these include cytological triage of all oncogenic types, partial genotyping for HPV 16 and 18, where these women could be referred, for example, directly to colposcopy, and newer technologies such as dual stain cytology. Now, these evaluations are going to need to consider not only cancer outcomes, but the implications on the effective specificity of these different triaging technologies on the screening process, and the implications in particular for colposcopy referrals. And they're also going to need to consider the relative effectiveness of different options for management of HPV positive but triage negative women and the different follow-up options there. And just to give you a flavour of this, this is another evaluation that we're presenting at this meeting, which looked at the cost effectiveness of 6-yearly primary HPV screening in England. And this slide actually shows the predicted numbers of women referred to colposcopy annually in England. The line shows current practice, and you can see that for a range of HPV-related strategies, we expect an increase in colposcopy referrals in unvaccinated cohorts of between 10 and 50%, with the highest increase observed if we actually refer HPV 16, 18 positive direct to colposcopy. But importantly, this is likely to change in vaccinated cohorts as HPV 16 and 18 is depleted. And you can see in this situation, we have only a marginal increase in colposcopy referrals, and genotyping becomes a much more efficient strategy. So in conclusion, HPV vaccination of pre-adolescent girls is highly cost-effective in developed countries, even in context of organised screening. At a cost per vaccinated individual of between $400 and $500, male vaccination may be cost-effective if female uptake is less than 50%. But female coverage and vaccine price work together, and we need to also consider the potential for a viable level of male uptake, particularly if female coverage rates are low. The cost-effectiveness of screening will require considerable re-evaluation in vaccinated populations. And primary HPV testing, of course, holds promise as an effective and cost-effective strategy in both unvaccinated and vaccinated populations. But much more detailed work needs to be done to look at specific management strategies and resource utilisation at the population level. Thank you.